Assalamu alaikum everyone. Ramadan Mubarak, and today our talk will be about a rare and a very interesting specialty in medicine that is called physical medicine and rehabilitation, or what is called physiatry. So our guest today is a Saudi board certified physiatrist who is working as a stroke program rehabilitation director at Sultan bin Abdulaziz Humanitarian City. She worked as the head physician for the Saudi Paralympic team in Tokyo Paralympic Games 2020. Let us all welcome Dr. Sarah Farhood.
Hello. Good morning in Ramadan time. How's everyone doing? Okay, so I switch from there.
Yes. And if you want to move, just put it on your map.
Okay, thank you. Hi, good morning or good afternoon. Thank you for the introduction. That was very sweet. So my name is Sarah Farhood, or Dr. Sarah. I've been practicing for around, I don't know, I'm still a baby physiatrist, that's what I always say. So I've been a senior registrar now for almost 2 years. And can I take this off? Okay. So in terms of physical medicine rehabilitation, before I start my talk or even like discussing it, how many of you know what PM&R is or physiatry is? Just raise your hand. Oh, wow. All right, so it would be nice to give you an introduction. This specialty is quite interesting. It's only new in Saudi. It's been here for around 11 years now, but it's been around since World War II. So this specialty was started around World War II when patients started having injuries such as amputation, spinal cord injury, and people with spinal cord injury were arriving to hospitals and dying very early. Their morbidity and mortality rates was very high. And there was no area of how to manage them or how to support them, how to help them live their life and continue. And that's when physical medicine and rehabilitation was basically invented or was born. I'll talk a little bit about why I chose this specialty, what brings this specialty to life for me. So a physiatrist is a doctor who has completed training in the specialty of PM&R and may be subspecialty in things like brain injury, neuro rehab, sports injury, pain medicine, pediatric, and the list really goes on and on and on. So this is what makes it easier for someone like me who does not know how to decide. I just kind of can switch between specialties all the time. In my patients, in my round, in my general unit, I go from treating a patient with MS to treating a patient with an amputation to treating a patient that is pediatrics and is coming in with cerebral palsy and needs injections for spasticity. So I'm never bored. I never have the same surgery or the same thing every day. Every day is different for me, and this is how I live my life in general. So what does a physiatrist do? A lot of people go, okay, so you're not a surgeon and you're not an internist, what are you? We're not a physical therapist also. So physical therapy, there are allied healthcare professionals who usually do the exercises for the patient. They would do the training, the management bedside. For you as a physiatrist, you are basically the captain of the boat. So in physiatry, we're a multidisciplinary team. I do not work on my own. I cannot work on my own. So I lead a group of physical therapists, occupational therapists, speech therapists, social workers, a psychologist or psychiatrist sometimes with the group. And we work together every week. We meet once a week. We discuss our patients in the unit. This is in the unit. And we create a plan for them. So for example, we have a patient with brain injury, post-road traffic accident. He's post-surgical, for example, decompression, craniotomy, and cranioplasty with the neurosurgery. So what happens after that? Do they go home? For us, no, they don't go home. They come into the rehab unit. And that's when we work on regaining the power that was lost. So there's weakness in one side of the body, regaining ability to speak, regaining ability to practice cognition, things like memory, attention. All right. So these are the things that we do behind the scenes that people don't really know, because in medicine, we're taught emergency management, go home. Do surgery, go home. No one can really do surgery, get amputated today, and then go home and put on a prosthetic device and walk. That is not realistic. You need to see a physiatrist, you need to see a physical therapist, you need to be trained, you need to be taught. So we're the people behind the scenes kind of working in that area. So again, does that mean that we do not do procedures? No, I actually do multiple procedures. So I work with pain management, I work with spasticity. Spasticity is when you have an upper motor neuron lesion and you have extra tension in the muscle or extra tone in the muscle. And we inject Botox in these muscles to release the tension, to help patients that, for example, have a certain deformity in the hand or the legs be able to dress, be able to move, be able to sit down. These are little things that in medical school we did not learn. So how many of you, when you take history, you say, okay, so how do you go to your bedroom, or how do you go to the restroom, or how do you eat after you see a stroke patient? Not many, because these questions don't come to mind. What you think of is past medical, history of presenting illness, past surgical, and then medication, allergies, social. We go further than that. We go functional assessment. Can the patient actually touch the top of his head? How is he going to get dressed? How is he going to move? How is he going to touch his phone? If he's a student who was in a road traffic accident, how is he going to use his laptop to continue his education? We're the doctors that ask these questions. So all my patients in my unit last from, let's say, 3 weeks to up to 6 weeks, 8 weeks of admission. So we get to know them, we get to have a relationship with our patients. We know their names, we know the watcher's name. We talk to their watcher or their companion. We tell them, we need you to do this. We need you to start trying to push him to do that. And for those who chose medicine for a huge part of like being human and humanity, this helps a lot. So I personally chose this because I wanted to be an orthopedic surgeon. And I used to sit in ORs with complete groups of men, just men. There was not a lot of women in the ortho rooms. And you'd wear the x-ray suit, and every day I was growing shorter, and I'm already very short. And I'd have back pain. And I asked myself, is this really what I want? Do I really want to be a surgeon? Do I wake up every day just to do surgery, or am I always finding myself in the clinics? And what I realized since my 4th year, 5th year medical school, I graduated from King Saud, I used to go to the clinic and during the break time or the free time, and I would cover with the consultant, and he'd let me do the physical exams and write down, and he would just say things and I would type. And that's how I learned MSK. I didn't learn it from books. I learned it from orthopedics telling me what to do. And that's how I gained my love for MSK, and I asked myself this honest question is, do I really want to be a surgeon, or do I just love working with musculoskeletal and sports injury and diseases, and do I like helping the patient, maneuvering the patient? And I realized that in my specialty, we do interventions like pain management. So you do under fluoroscopy, nerve blocks, things that anesthesiologists or family medicine also go into, we go into. We do procedures, or we do investigative tests like EMGs. These are things you see neurologists do. Abroad, I did some training in Toronto, and that's where the physiatrist is completely in control of EMG. You'll only see a physiatrist doing an EMG. And these are highly needed in Saudi. We don't have a lot of Saudis doing them. We don't have a lot of physicians that are very, very qualified. So that's a really interesting field. In my personal practice, I'm currently a stroke program director. Not really out of choice, but I enjoy it. I enjoy my stroke patients because the best thing about stroke is the improvement. You will see improvement. So you do see the patient coming in quite depressed and then moving into a little bit more optimistic future. And I also work with amputee medicine. So I deal with people post-gangrenous amputation or post-traumatic amputation. So young, old, congenital, even children come into my clinic. And I work with prosthetists and I work with physiotherapists in the same clinic. We sit with the patient and we tell them, you need this, you need that. And I think you need a sports limb. No, I think you need a cosmetic limb. So every patient's different. All right, so I kind of went briefly with talking about my experience and trying to explain to you all the fields you could go into if you choose to become a physiatrist. So you could go into amputation medicine, brain injury, cancer rehabilitation, cerebral palsy rehab. We work with dysphagia or swallowing rehab, MS and neurological diseases, things like muscular dystrophy. We also work with osteoarthritis, just general MSK clinics, pain clinics, rheumatology rehabilitation also. Spasticity and movement disorders, that's where you find yourself injecting more Botox, injecting more medication, which I do quite a lot with my stroke patients. And then spinal cord injury, which is very core, and spine pain, sports-related injuries, which I also practice, and stroke. So a physiatrist is really nothing without the team. So if you're not a team worker, you do not know how to communicate, it's very difficult to work in physiatry. You have to be able to take something from a physiotherapist or from an occupational therapist and be like, okay, because we usually are very optimistic as physiatrists. We go, okay, within 3 weeks, we want him reaching steps, we want him, and the physiotherapist is just like, listen, I'm pushing him, he's not cooperative. So there's a lot of understanding human brain, human personalities. You have the same patient coming in with the same disease, but they don't leave with the same functional ability. And this comes from understanding psychology, understanding a person going through depression or a person going through a supportive family or someone left without family. So these are things that we manage and deal with a lot. So you would expect having to deal with a social scenario every once in a while. And that I like. So I found this online and I can speak about my reasons why I chose physiatry, but I'll read this out and then I'll tell you my personal reasons. So 7 reasons you should try physiatry. First thing is lifestyle. So even internationally, even in Northern America, it's ranked the top, one of the top lifestyle specialities. You practice, but you're on call, you stay home, or you never get called. Your patient's in a rehab unit. He's done with surgery and he's done with the acute AKI or the internal medicine issue. We do not accept patients who are suddenly active or they have an issue or they're infected. We don't. We take a patient when he's ready for rehab. So you also have your personal time. When you go home, you go home. So I like not taking my work home. I don't like being a doctor at home. And I like being a doctor in the hospital and then that's it. And some people don't. Some people take doctor to Twitter. Some people take doctor other places. And that's okay. That's who they are. So young, dynamic speciality. Like I said, you mostly be working with young people. Physiotherapists, occupational therapists are not really older people. They're young people. They have to carry the patient. So the environment is usually we're all joking around. We're all in our like 30s, 40s, just joking around. And it's a really nice environment. So even your patients, they vary from all ages. So some of them we call uncle and auntie. And we're just walking around and being doctors and it's fun. So it's a really nice environment. Early career opportunities. This depends on where you live. So in Saudi right now, it's like I said, the baby specialty. We have multiple private rehab centers. I work in a private one right now, but in terms of governmental, we have 3 here in Saudi, in Riyadh, and 1 in Al-Ta'if. That includes National Guard, military hospital or Al-Askari, and KFMC. So exciting breakthroughs. Yeah, well, definitely, because we're managing people post-injury. So we're seeing things in spinal cord injury that are still studies and still in the way, but you see things like stem cell transplant that are helping people walk again, or you're seeing maneuvers and we're seeing equipment. We're seeing sports equipment for amputees that makes them faster than any of us, that makes them like the heroes they are in the Paralympics. We're seeing equipment in wheelchairs, in equipment for eating for people with Parkinson's disease that makes them feel like they're not living with a tremor. So you learn a lot about how to function in society if you had a disability. Exciting breakthroughs, growing need. There is a growing need, obviously. I mean, I am there's a big growing need. So I'm probably the 5th or 2nd generation of graduates from this board. It's a baby board. It's not the internal medicine or the general surgery. So we do need more physiatrists. We need physiatry. We need people in cancer rehab. We need people in burn rehab. We don't have a single Saudi pediatric rehab. We have a few brain injury rehab, a few stroke, and a couple MSK and pain. That's what we have right now. And imagine the list you just saw. And we just had one guy who came back with amputation medicine from Toronto. So we're growing and we need people. Academic and leadership opportunities. Obviously, I went through medical school never hearing of physiatry. I went through medical school with the intention of becoming an orthopod. And then around my last year, my colleague who was a demo just grabbed me and was like, "You are not an orthopedic surgeon. Go read about physiatry. There's a board in Saudi." And that's how I figured it out. And that's how I did my reading. And I think us reaching out and you reaching out to me helps you actually read a little bit about the specialty. So maybe specialty is not for you, but maybe it's for your friend that did not attend today. And you're like, "Listen, today we had a talk. This person is definitely who you should be." And that's how I figured out physiatry, by a friend telling me, "I think you should go the other direction." So diverse opportunities, just like I mentioned, here in Saudi specifically, even internationally, you'll always find a center. There's always even work in private, because you can work from everything pain to literally burn. So there's no limits in physiatry. So a little bit about the Saudi board, if you're interested in that. It's a 4-year board. It's around 5 centers. Currently, there's a KFMC, military, and then Haras also. And currently, the hospital I work in has just opened the program there. I work in Sultan bin Abdulaziz Humanitarian City. And there's also a center in Ta'if. So these are the centers where you would do your training. And we take like 3 residents, so you wouldn't find a big group of residents. So you're gonna find your contact to consultant is this close. So I teach my residents firsthand. They don't have to go through a senior registrar or a senior resident, and then maybe they'll get teaching from the consultant. No, every day you get teaching, because we literally have only them. So we're still small. Lifestyle. So I'll talk about my lifestyle. This is what made me really, really choose the specialty and go, okay, that's where I'm going in MSK. I'm a big person in terms of creating a healthy lifestyle. And what I mean by healthy lifestyle, I don't mean protein shakes and things like that. I mean healthy lifestyle, that I'm sleeping enough, that I see my family, and that I actually don't spend most of my time driving in the streets from one clinic to the next, from one surgery to the next, and that my life does not become my job, but my job complements my life. And I think that's what changed the way I think of living. So for me, having time to do my runs, having time to teach the classes, I teach yoga. So on the side, these things, although they feel complementary when you're young, you're like, no, I can totally ditch all of that and I'm gonna go 100% into this. Once you get older, you start realizing if you did not have these things, your quality of life, which is what we manage in our patients, really just starts going down. Because as much as you can get from your job, whether it's the salary, whether it's the recognition, or even creating these relationships with other established physicians and researchers, at the end of the day, you do go home on your own. So what are you adding quality towards yourself that does not go on your CV? Kind of was my question to myself before I chose what I was going to do. Practice. So my practice is quite chill. I have 2 clinics a week. I have an inpatient unit. I manage a stroke unit with over 30 patients. I round once a week. I do a few admissions over the week. As I said, like none of our patients are having acute high WBC and they're having a fever and we need to, so most of our patients are stable. And that makes it easier for me because I never liked the emergency setup. I never liked the idea of rushing into ID. I like to think slowly. I like to manage my patients slowly. So my practice is quite easy. I also work pro bono. I volunteer as a sports physician with a few teams, and sometimes I just volunteer work because I believe if you want to do sports, you need to just do. You cannot wait for the opportunity. You need to push yourself in front of a doctor, in front of a team in front of whatever and be like, can I attend? Can I just help? Maybe I can help. And I attend training sometimes and someone sprains their ankle, and that's the easiest thing. And an internist or even an internal medicine intern first year can manage a sprain. But the idea is about being there and then gaining recognition and becoming a better physician with practice. Learning. I have so much time to read. So I created also a little online, not platform, but I created a little like PM&R notes. And around my third, fourth year of residency, I would make these notes on my iPad and I draw them and make them colorful for me to learn. Because when I went into the board, there's no way I can cover all these topics. You saw everything I mentioned. So you need to study geriatrics, you need to study pediatrics, you need to study people with certain surgeries. So you need to understand what is an ACL repair. You need to understand what is an amputation, what type of amputation. So it's not about picking up after your examination or your board certification is, are you a good physician, 1, and then can you be a good physiatrist, 2. So the amount of studying in the board, and I think that is the only negative point, is if you're not a studier, it's a lot to learn because you're learning every type of person in the community, and then you're adding to that a disability, and then you're adding how to manage a disability. So you learn normal gait, and then you learn abnormal gait, and then you learn how to fix the gait, as opposed to ortho learns fracture and they fix fracture. They don't learn what happens after or before fracture. Who cares? All right? So learning, very, very important. So you need to be an active learner, an active reader. That's very important in physiatry. So that's a little bit of pictures of things that I do. That's me with Abdulrahman. He was our Paralympic champion. That's when we were in Tokyo 2020. That's the team down there. That was a really good experience for me as working. So I worked with a team volunteering around 2 years before I went to Tokyo. And then in Tokyo, I was totally volunteering. But there, I created connections with physicians internationally in the Olympic Committee. And this is how you start in sports. Like, don't believe anyone who tells you you just need to take the degree. No, you need to go out there and work in sports. And then that's my running community. That's my run team. I run as a coach for Adidas, and I train people to run. And this adds to my life. So I put this here because I want you guys to understand there's more to life than residency and getting your board and getting your steps done. That's great, but what happens after that? Like, did you create the family you want? Did you create the quality of life you want? And then that's me giving a lecture in, obviously it was via via computer in my hospital. I was giving a lecture about stroke rehab. And then in the background, that's also my run team because they're in every little presentation I do. And so I didn't want to talk too much because I wanted you guys to ask me. This is the place I work at. It's purely a rehab center. So it's beautiful. There are gardens, there are areas for our patients who need to go out and sit out in the garden. It's quite a beautiful place. It's a little bit far away. We work in Bimban. So let me talk a little bit about how you can become a physiatrist. So first thing is you need to try it. I believe that as much as I sit here and I try to explain it to you, you still don't understand what physiatrists do, I'm pretty sure. So get an elective, go do an elective. I think I did electives in military, KFMC, I did 2 electives in Toronto rehab. And my experience in Toronto was very different than my experience here. Here I was mostly an internist, intern. I was working in medical cases. It wasn't pure rehab. And then when I went abroad, I had pure rehab experience. And the best thing about abroad, I think, is they trust you. They really trust you. They're like, okay, go ahead. You go ahead with that hydromorphone. Give whatever dose you want. I'm like, really? It's like, yeah, go ahead. And I learned early on, around 5th year medical schools, how to be confident and how to ask. There's a way to ask your physician without looking like you did not read. So there's a way to ask your consultant without looking like you really have no idea what you're doing. So how to ask. And read about the specialty. Open John Hopkins Rehabilitation Center. And I tell you to read more abroad than read here because they're practicing pure rehab. We have just started. So we're still kind of filtering in the cases that should not be admitted, the ways that the residency shouldn't be done. But with that said, I would not have done my residency abroad, although I did get the opportunity. But doing it here, practicing here, gave me more time to study, gave me more time to work in sports. So by the year I graduated, I finished my board. The next year I went to Tokyo. Abroad, if you want to do that, you need 4 years with a team before you can even say the word Olympics or Paralympics. So we have fresh opportunities here. And if you have a physician in your corner, someone working high up who thinks you're good, they'll push you. So that's why I chose here, because I felt like it works with my type of life. I was already working anyways as a trainer, so I wanted to stay here. And you can contact us. So we recently started the Jamia Saudiya للتأهيل أو طب التأهيل, or the Saudi Society of Payment. So they have a Twitter and an Instagram. I'm not really involved, but they're great. And then you can connect with me on these Instagram, Twitter handles if you like. But right now, I think we should go into questions if you have any. And I'm done. Thank you.
Any questions for the slide? Assalamu alaikum. I wanted to ask you, what was your experience like working in the Paralympics? Like, what was your role? What was your favorite experience?
All right, thanks for the question. So I worked as head physician for the Saudi team. So you're in charge of every single athlete in terms of checking up on them on a daily basis. Now, when you work in sports, your athletes are usually the healthier than the regular person in this room. They're fitter, they're healthier, they already take care of their sleep and everything. But you work with them in a high stress environment. So in terms of Olympics or Paralympics, what we see is the final game and the medal celebration, but that's not what happens. What happens is they keep drafting them, they keep filtering them out. So the Olympian or the Paralympian is almost trained, almost into a test every day. So he's doing almost every 3 days. They're going into a filter process so they can be nominated to be in that last 10 people that go in for the medal. So I was really dealing with a lot of stressed athletes. A lot of them were just like, I don't know if I want to do it. And because you're the only physician, there's no psychologist with you. So you need to take care of the mental health before the physical, because most of my athletes were quite well physically. Like, they did not need much. Maybe there's that instant like muscle strain, or they're too tired post-exercise and they need some kind of prescription. And you as a physician, so you get proper education before you go. You get education from WADA, which is the World Anti-Doping Association. And you get meetings with doctors where you arrange your patients and you need to know what prescriptions are on, especially with Paralympics. So these are these are athletes who have disabilities, who are living with disabilities. So most likely they are taking some form of medication. We had an athlete with spinal cord injury, so she was taking medication for her bladder management. I needed to check that was allowed, because any illegal drug tests were completely out, everyone. So things like that you need to be more cautious of, that you don't think in a normal regular clinic. So in the Paralympics, I went to the athletes in their trainings, in their games, in their competitions. You're part of the team, but you don't work in the actual field, you work post-field. So you don't work in the emergency team, but you work post. And I took them to the polyclinic, we worked in the polyclinic. So in these like meetups or in these games, there's usually a built-up clinic. And this was a different scenario, so we weren't allowed to go out into the city. It was COVID, right? So we had daily PCR tests, we had things that we needed to manage that previously, or the team physician did not do. There was no such thing as making sure everyone is in their PPE and giving their PCRs, and if the PCR is positive, where am I isolating them? Things like that we were managing that we did not expect. But yes, you do manage injuries, but mostly it was about counseling and then giving them that, did you do your ice bath, did you go? So you're basically like babysitting them a little bit, but in terms of recovery.
Doctor, mashallah, you said that you are a runner and you're a coach and you do several things. How did you manage being a doctor and your sport life?
Yeah, I started young. I started in medical school. I was 19 and I took a job. I was working as a trainer in the gym. Before, we did not have open fields for ladies to work out outside. It wasn't very acceptable, but now it's kind of okay. So I used to work in gyms, and I decided I used to just go to the gym to work out. And one day the manager was like, "Hey, why don't you train people?" And I was like, "Okay, I'm 19, whatever, let's do it." And then from then I never stopped. It's been almost 11 years now, and I've been always teaching. And I think that's what helped me with my studying, because I had an outlet. I always had an outlet, and I always considered sports an outlet. And some people it's not sports, some people it's reading or their friends or their family, but find an outlet, I would suggest. And yeah, and now I make time. I run before I go to work. I wake up at 4:30, 5 a.m., back Salat al-Fajr, run, and then go to work. You need to have some kind of system in your life for your life to move through smoothly, and that's what I believe in. So yeah, you make time if you love it.
Well, thank you so much, Dr. Sarah, for this very inspiring talk. And thank you so much for focusing on the factor of work-life balance and how you chose this specialty because you felt that you can achieve like both, being patient-centered and helping patient care, but at the same time fulfilling your own and personal needs. So thank you so much for this talk. I have a question. Especially that we are really trying to promote health among the community. So how do you think from our role as Alfaisal University, we can promote health towards this very important specialty in the community? Especially that, it's not only that the medical students don't know about it, but even further, they, as you correctly said, it's either the physiotherapist or the surgeon or a neurologist, but physiatry is not really shed the light on probably. So
yeah,
your thoughts, please.
Yeah, I totally agree. I think things like these help raise awareness. Maybe some of you never knew there was a board like this, and it's such a shame because it's a beautiful one, and it's ranked one of the top 3 competitive in Northern America. So it ranks down with ophthalmology, dermatology, plastics, PM&R. My friend was a demonstrator, and she waited 2 years until she got her acceptance with her steps and with everything. It's a very competitive specialty because of all the positive qualities. And I think the best way to raise awareness on this is really, I think, including it in the curriculum. So I've heard a few universities have started one lecture on rehabilitation post-injury in the orthopedic rotation. So you can include that, or you can include that with MS or a neurology lecture at the end of the lecture. Because I think we need to start asking as physicians, what happens to my patient after I give him the medication? We all have people in our family who had an MI or a stroke or a burn or a traffic accident. What happened to them after? Was it okay that the doctor sent them home post-surgery? So these are the questions that we ask as physiatrists. What can we do after things are done? So yeah, I think raising awareness is very important. I try to, and a lot of physiatrists try to really. And like I said, we're very small, because I think the more you know, you can also, as medical students, be like, hey, we want a lecture on MS rehab, or we want a lecture on spasticity management or pain management from a physiatry perspective, because it's part of your education. And by the way, to this day in Canada, in America, they also say, we don't know what physiatry is. To this day, they make jokes about it. So it's not like we're way behind. Yeah, any more questions?
Doctor?
There's a question. Yeah, oh, sorry.
I have 2 little questions.
Go ahead.
First, since here in Saudi Arabia it's not established that much, Are the salaries different?
No, you get paid as much as a neurologist or a neurosurgeon. You get paid على حسب in Saudi على حسب السلم الوظيفي. So I'm currently a senior registrar, and then when I become a consultant, so there's a natural way of salary. Obviously, in the future, if you decide you want to up your pay by working private or working in other sectors of the medical field, that is up to you. But you get the same as a physician, yes.
Yeah, thank you. And the other thing, how do you ask? So you mentioned the point where you can ask you can ask someone without appearing like you don't know anything.
Yeah, well, the best way to ask, like you don't know, you need to read about it, make your assumptions, and question your assumption. So read about the topic you want to ask about, make your questions, and then because there's always going to be a reaction for every action, right? So once your consultant or your teacher tells you, oh, this is the answer, then you will follow up with a question if you've read. If you do not follow up with a question for me, it means you did not read and you really don't know what you're. So follow up with a question, read about it, and then ask. Yeah, sure.
Okay. My question is, when do you think people should seek physiatrists? You know, like, why should I meet a physiatrist? Why should I go to one? Do you recommend people, everyone goes to one, or what is that?
So for Physiatry, we manage people post-injury, post-disability. I recommend anyone we also manage chronic pain, but I'm going to put that on the side because just like if you have chronic pain or you go to a pain specialist, and you will find physiatrists who are listed as pain specialists here in Saudi. You'll find them in private clinics. But a physiatrist in a general, let's say, governmental sector, usually we take patients post-stroke, post-MS, post-spinal cord injury, amputation, hip replacement, knee replacement, pediatrics that are born with a congenital disease or a genetic disorder and they need help. So people born with certain genetic diseases have inability, for example, in mobility. So I'm going to talk basic terms: mobility, hygiene, changing, feeding. We teach the family. We give them a perfect device for ambulation, for example, a wheelchair that is electrical. So we think of solutions to make the life of the patient with us as independent as possible. So that's the type of patient that I assume I would see in my clinic. But does that mean I don't see the low back pain patient and the patient who's like, something's off with my toe? I see them a lot. And that's okay, because we do everything really.
One last question, please. Doctor, I missed most of the part. Yeah, unfortunately. So my question is, what's the difference between physiotherapist and physiatrist?
All right, yeah.
We didn't talk about it, I don't know.
No, it's all right. I'd like to repeat that point because I don't want you guys leaving here not knowing the difference. So a physical or a physiatrist, a physical medicine rehabilitation physician is a doctor. You go through medical school, you go through residency. You manage patients with multiple disorders or multiple disabilities. You manage them with medication and you manage them with non-pharmaceutical ways. Non-pharmaceutical comes into what? Physical therapy. That's where you work with a physical therapist or an occupational therapist or all types of therapists that we love and share our practice with. They work on these things. For example, you have a patient with osteoarthritis, severe pain in the knees. Is the first thing that you do is go and inject intra-articular injection? Of course not. First thing we do is, hey, physiotherapy, can you start taking him to aquatics? I put a referral in the system for aquatics and for physical therapy. Can you start taking them to sessions? Strengthen the quad. So you need to know the science behind managing OA, for example. So physical therapy, aquatics, maybe some pool therapy, and then I could start with some local. And then after that doesn't work, that's when my active work comes in. Maybe I inject, maybe I do an x-ray, maybe I need this, maybe I refer to ortho, maybe it's grade 4 and he needs a knee replacement. So you're basically, like I said at the beginning, you're the captain of the ship. You decide where the management goes. And most of the time we go non-pharmaceutical, working with a physiotherapist, but you are not the physiotherapist. The physiotherapist goes with the patient to the gym, gives him exercises, trains him, And then there's communication between you during the rounds where they're like, okay, patient achieves standing, patient's achieving balance while sitting. And you're like, okay, and then you start managing a plan. So part of your residency is actually in there's understanding what a physical therapist and occupational therapist does, so that when you go up to them with a goal, you're realistic and you know what they do. You understand the tests, you understand the maneuvers, and you're a core part of this team. Without a physiatrist, a rehab unit cannot move, and that's why you need to like delve more into electives, and that's why I recommend doing an elective if you have the time. All right. Okay, thank you.